So I now have the privilege of introducing our first speaker and Mary Glover lecturer, Dr. Beth Pringle. Dr. Pringle started her journey in Alberta as a physician, and after a brief stint as a family doctor, completed 2 residencies, one in internal medicine at the University of Calgary and a neurology residency at the University of Western in London. She completed a fellowship in MS clinical trials in London, followed by a neuromuscular and EMG fellowship at the New England Medical Center in Boston. She joined the Faculty of Medicine at the University of Ottawa in 1994, where she currently practices as a staff physician. Her clinical focus is on neuromuscular disorders, particularly myasthenia gravis and primary lateral sclerosis. She's actively involved in the work of the University of Ottawa Stem Cell Research Group as it pertains to the treatment of immune-mediated neuromuscular disease, and was part of the first ever stem cell transplant for the treatment of myasthenia gravis. She's been very active in medical and nursing education throughout her career and is a past graduate of the University of Ottawa's Distinguished Teachers Program, as well as a very popular lecturer both for CAN, Ontario East events. She still lectures and tutors in neurology and shares her passion for the history of medicine as part of the Welcome Lectures for incoming medical students each year. We are honored to have you share your passion with us today. Welcome, Dr. Pringle.
Well, thanks so much, Ellen, and thanks everyone for inviting me. I'm very honored. I'll see if I can figure out how to screen share. Let's just see if we can get there. That should do it. Share, so you can see my slides there, I'm hoping. Is that right? How's that?
Yes.
You can see the slides and hear me. Well, I had a start that was all rehearsed. But I have to say, Lynn jogged my memory there, because when I first came to Ottawa, believe it or not, I was the first woman faculty member that neurology had ever had. Sue Christie went ahead of me as a neurologist, but she wasn't on faculty. And I would still say that my earliest and to this day best friends in Ottawa were the neurology nurses. And I still remember, I don't know if any of you remember Andre Hopper, but I had a little tangle with some of the administration at some point, and Andre came up to me and said, "Don't let the bastards get you down." So that's my memory of starting in Ottawa and how supportive the nursing community was to me. So we will jump right in here. I'm trying to get, do you have everybody's pictures on the side of your screen? I'm trying to figure out how to get rid of that.
We don't see that. We just see your slides.
Good. Okay. I'll just have to look at all your beautiful faces, as long as they're not obscuring the slides. So the tale of 2 itides. You probably know itides is the plural of itis. So it's the Greek suffix meaning inflammation. So we're going to talk about 2 inflammatory diseases, encephalitis, lethargica, and poliomyelitis, that changed neurology, and as I hope to convince you, changed the world. The story starts a little bit more than 100 years ago in 1916. And there's 2 epidemics of these neurologic diseases, now largely forgotten, in the encephalitis lethargica, which we'll call EL, and poliomyelitis, as you all know, is polio. They're both inflammatory conditions affecting the gray matter of the central nervous system. In the case of polio, definitely viral. And in the case of EL, possibly viral, although we still don't know that for sure. EL affected the midbrain, the mesencephalon, the diencephalon, and the basal ganglia. And of course, polio affected the anterior horn cells of the spinal cord and the medulla. Between these 2 disorders, they killed millions of people and left millions more neurologically disabled, and they changed medicine and nursing in dramatic ways. And they certainly changed the world's attitudes toward the disabled, and probably affected world geopolitics via celebrity victims, which I'll show you a bit about. And both would weirdly vanish by basically the middle part of the last century. In the case of encephalitis lethargica, why it vanished remains one of the great mysteries of all time. And in the case of polio, it was the result of one of the great medical triumphs of all time, the polio vaccine. And needless to say, both of these disorders have some interesting echoes here in the era of COVID-19. So we'll start with encephalitis lethargica. It's also known as von Economo's disease, because von Economo was the Austrian neurologist who first described it in soldiers in World War I in Vienna. And what he described was this thing that would become known as sleepy sickness, not sleeping sickness, which is African trypanosomiasis, but sleepy sickness. And it caused a global pandemic that lasted about 4 years and in its wake affected about 5 million people. And as you can see, it was really big news at the time. About a third of the people that had this died in the acute stage. But weirdly, as I mentioned, it virtually disappeared after 1930. What von Economo described was a sort of a non-specific illness, a kind of a low-grade fever that would quickly evolve into a marked disturbance of consciousness. For the most part, this was severe somnolence or lethargy, but it was deep somnolence, but they could be roused. So this was not coma. You could rouse these patients and they would talk to you and be appropriate, and then they'd fall asleep. It was almost like epidemic narcolepsy. And there are descriptions of the patients literally kind of falling asleep in the middle of eating with food in their mouth, or actually walking and they would fall asleep. In a smaller percentage, it was the opposite. They would have trouble falling asleep and become terribly, terribly insomniac. Unlike narcolepsy, though, they also had focal neurologic signs. And the folks who died of this, von Economo looked at their autopsy material, and based on where he saw the lesions, he postulated a sleep center in the anterior hypothalamus and a wakefulness center in the posterior hypothalamus. And he would be eventually proven to be quite right about this. Now, this really is the dawn of sleep medicine, and it probably doesn't seem all that surprising to us nowadays, but at the time, this was a really out there theory, because the theories about why people did fall asleep were really kind of hocus pocus at the time. So there was one of my favorites was dendritic retraction, that the theory was that at night when you became sleepy, all your dendrites would retract into the neurons, and then in the morning they'd go back out and connect up in synapses. Or there was other theories where sleep was just a question of toxins building up in your brain during the day, and when the toxins got to a certain level, you'd fall asleep and then the brain would magically clear them. So there really was no good science about what exactly was happening in sleep until von Economo and Encephalitis lethargica. Now, I mentioned the focal neurologic signs, and they're mostly, for the most part, they were signs that you'd expect for disorders in the midbrain and high pons. So they would have ptosis of the eyelids, pupillary irregularities, dysconjugate gaze, nystagmus, and these things called oculogyrate crises. And you don't have to take my word for it, because I'm going to show you a video. They were very dramatic events, and some of you, can I use the phrase old timers, might recognize something similar in an oculogyrate crisis to the sort of reactions you could sometimes see to some of the older anti-nauseant medications in the post-op world, like Stemetil. I don't know, do people still use Stemetil? And metoclopramide. But this is, of course, long before those medications were even dreamt of. So what oculogyrate crises were these forced conjugate gaze with segmental dystonia of the neck, and often associated with sort of forced thoughts, compulsive thoughts that the patients had no control over. So it's quite terrifying. It was, one patient described it as like she was being possessed by a devil, because the movements were out of her control, the thoughts were out of her control. So here's a video from the 30s.
This young woman is in an oculogyrate crisis. The dominant feature is the tonic deviation of both the head and the eyes. This oculogyrate crisis is accompanied by retrocalis and an open mouth, followed by rapid blinking of the eyelids.
So that was oculogyrate crisis. And what happened to these folks that did have encephalitis lethargica is up to 40% of them would die, because this is, ages before NACUs or ICUs. And in those who died, as I kind of touched on already, the inflammatory changes were most marked in the midbrain and the diencephalon. So right there. So you can see that it's right where von Economo postulated the sleep center, and it's right where all of the third and fourth cranial nerve nuclei are. What was really interesting, and the reason that I find this so fascinating, is what happened to the people who didn't die. So of the survivors, 70% of them developed long-term sequelae. Some of them had just merged seamlessly from the acute illness, but more often they would seem to have completely recovered. And then weeks, months, or sometimes even years after they were supposedly fully recovered from their encephalitis lethargica, they would develop these long-term side effects. And as you can see, there were a number of them. There were books written about all the various long-term side effects of encephalitis lethargica, but we're going to concentrate on the two most important and the most frequent, which were the hypokinetic states and the mental and behavioral changes. So the hypokinetic states were essentially Parkinson's. And this was the first recognition that Parkinsonism could have more than one cause. So it wasn't just Parkinson's disease. There were other things that could cause Parkinsonism. It differed, however, from standard Parkinson's disease in very important ways. Most importantly was the youth of its victims. Look at this histogram here. That there's kids. These are, you know, very young children, teenagers, and young adults that got this. Just unheard of in Parkinson's disease. And they all have the stooped posture and very rigid and extremely bradykinetic, as I'll show you. They didn't have the classic pill rolling tremor of Parkinson's. When they did have a tremor, it was a lot more coarse and lower frequency. Many of them also had associated motor tics and compulsions and other neurologic disorders. And I'll show you a few videos of post-encephalitic Parkinsonism. So here's a guy who's only in his early 30s, and you can see he's got a very coarse tremor, a festinating gait, stoop posture. This gal was, I think, 12 or 13. You can see she's having to be held up from behind, very coarse tremor. And then that same fellow that was in the first video, this is him outside. And anybody who's ever worked with Parkinson's disease will know this term, festinating gait. So the festinating gait is described as chasing your own center of gravity. So as Parkinson's patients walk, their steps get closer and closer together and also faster and faster. Well, this is the most dramatic festinating gait I've ever seen. You can see his attendants by the end are kind of struggling to keep up with them. And again, this is guy that's only about in his early 30s. In addition to the Parkinsonian gait and the tremor and so on, they also had profound psychic slowing. So it's described as bradyphrenia, slow thinking. And von Economo himself described them as extinct volcanoes. And they would show this unusual form of catatonia called catalepsy, which is pictured here. This isn't a video, but it could be, because what catalepsy is they would form these statuesque postures, and they would stay unmoving, frozen in these postures for hours or even days, or sometimes even weeks, awake. So they weren't locked in. They were awake, but they had profound slowing of thoughts. So they were kind of aware of their environment, but didn't interact with it. And in a small percentage of these people, they also demonstrated this weird thing called kinesia paradoxica. So kinesia paradoxica was this phenomenon where somebody who was frozen, like this lady in the picture is, where there's a sudden unexpected stimulus that will kind of snap them out of their frozenness briefly, and they'll resume having normal motor function for a transient period of time, and then go back to the frozen state. And the most famous story about this, and I have no idea if this is true or just apocryphal, was there was a poor fellow that was frozen from encephalitis lethargica, and the well-meaning caretakers took him out to the beach in his wheelchair, and he was sitting there very Parkinsonian and frozen, and some poor soul started to struggle in the water and start to drown. And this guy, to everyone's astonishment, leapt out of his wheelchair and dived into the ocean, saved the drowning person, then came back, sat in his wheelchair, and was frozen again. So that's the most dramatic kinesia paradoxica. Here's some less dramatic examples. This young man, you can see he's got very low blink rate. He's got rigidity. He's very bradykinetic and presumably bradyphrenic. But look what happens when somebody throws him a ball. Boom, 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 boom. So that's kinesia paradoxica. This is a young fellow with, again, probably only his late 20s or early 30s, with a very bradykinetic gait. He's got dystonic posturing of his arm, very short kind of step length, shuffling gait, very, very slow. He's being asked to go out and walk in a circle and come back. And you can see it's just a very slow process. But look what happens when they give him books to step over. Boom, boom, boom. So a visual cue. And it doesn't even have to be books. They put paper on the floor, and he just steps along just smartly. Nobody really understands what's happening in these kinesia paradoxica cases, but it just goes to show you that there's a lot more to the motor system than what we understand. The other main category were the psychiatric disturbances, and these were really prominent in the children. They would get very hyperactive at night. They would, go from being sweet little kids to these awful, horrible monsters. They were described as moral imbeciles and demonstrated malicious cruelty. And you can see from these papers down in the early 20s and late 20s that there was a big topic of medical discussion about what to do with these behaviorally ruined kids from the Encephalitis lethargica outbreaks. And they also demonstrated a lot of self-mutilation tics. So this is a kind of an awful video. This young lady, as you'll see, she walks towards the camera. You can see she's hemiparetic there on the left, but I want you, as she walks towards the camera, to look at her eyes. And this young lady, one night, locked herself in the bathroom, and using only her own hands, she pulled out all of her own teeth and both of her eyes. And when asked later why she did it, she said she was compelled to do it. She had no control over it. She was compelled to do it. So it was a bizarre group of psychiatric disturbances that people manifested. Now, what on earth caused this? And the short answer is we don't know. There was a lot of thought, both at the time and later, that maybe it was related to the Spanish influenza epidemic of 1918, 1919. I don't have to tell you about that. We've all heard about it and feel strangely akin to these folks from this old picture. There was a little bit of support for this in that the timing was suggestive. EL often, but not always, followed the flu. It might explain why it disappeared by the 30s if the virus had mutated, but there were later flu viruses that were similar to, not identical. Oops, I got somebody's microphone on there. In 57 and 68 that didn't show anything that looked like EL. The doctors and nurses at the time had no doubt that these were two different diseases because the influenza patients had very high fever. It was extraordinarily contagious. So if one person had it, everybody had it. And that didn't happen with Encephalitis lethargica. And the experimental evidence was a little contradictory too. There were neurotropic influenza viruses that were localized to the substantia nigra, so right where they would be in a position to cause something like Encephalitis lethargica. And there were even H5N1 models that showed dopaminergic neuron loss. But the 1918 virus turns out not to have been neurotropic, so that seems pretty unlikely. And more importantly, when they took archival tissue and did RNA probes trying to see if there were influenza markers in the Encephalitis lethargica archival brain tissue, they did not find it. So it certainly wasn't a direct result of the influenza virus, but there may have been some sort of a relationship. Something I found really interesting was this series of papers in about 2004, 2005 by Russell Dales and colleagues saying that maybe it was autoimmune. So even though I said Encephalitis lethargica essentially disappeared by 1930, there still are sort of sporadic cases. And in fact, I was convinced that I had seen one about 15, 20 years ago. And that's how I became interested in it, actually. Which, by the way, if you ever want to really see an oculogyric crisis, leave a 1918 case report on an ICU chart and everybody's eyes roll uncontrollably. But anyway, that's another story. So Dales showed that in some of these cases that looked like they had Encephalitis lethargica, they could actually demonstrate autoimmune activity in the basal ganglia. And this was all at the time of this at the time, very trendy and in the news syndrome. If any of you are in pediatrics, you'll know all about the PANDAS syndrome. So this stands for pediatric autoimmune neuropsychiatric disorders associated with streptococcal infections. And this is a real thing where little kiddies that get infected with streptococcus, a tiny percentage of them can go on to develop motor tics and neuropsychiatric disturbances. But for a while after it was first described, everybody had it. And in the context of this, it started to look possible that maybe EL was autoimmune. And then, of course, a few years later, we have the description of NMDA encephalitis. And a lot of these patients do look like Encephalitis lethargica. Then, of course, there's case reports of people with acute psychosis, acute sort of schizophrenic presentation, showing antibodies to dopamine receptors. And probably most compellingly is a relatively recent proof that type 1 narcolepsy is in fact an autoimmune disease. So there's good reason to believe that maybe EL was a funny autoimmune disorder. But you still, any of these theories, you still have to explain, why did it disappear? That's the mystery. So if it was a virus, did it mutate? Did we get herd immunity? Of course, that's a phrase we all know all about. Or if it was autoimmune, was it that in the 1930s, sulfa and penicillin kind of came online, and so there's far less untreated streptococcal infection? But the reality is we just don't know. And because we don't know, we really have no idea if it could return someday. That's kind of the scary thing. There's a lot of legacy talking about Encephalitis lethargica. I already touched briefly on the fact that it was the birth of sleep medicine. It really cemented the role of the basal ganglia in movement disorders. And it's really the birth of the kind of foundation stone of neurochemistry. So the development of antipsychotics and certainly L-DOPA came right out of the encephalitis lethargica experience. One of the stories is that chlorpromazine, which had first been developed as a sedative, very quickly was recognized to be a very effective antipsychotic. But a young fellow named Dr. Steck noticed, looking after some of the early patients treated with chlorpromazine, that they started to develop side effects that looked very much like what he had seen as an intern working in Vienna with encephalitis lethargica patients. And this led quite quickly to the idea that these drugs must be working at the same part of the brain as the encephalitis lethargica pathology had been demonstrated, i.e. the basal ganglia and midbrain. And that led very quickly to Kathleen Montague in 1957, localizing dopamine to the basal ganglia. And then Canadian Dr. Hornikowitz showed that Parkinsonism was a result of a striatal dopamine deficit, and then within a few years did the very first therapeutic use of DOPA in Parkinson's patients. And in a nice little bit of karma, the very first patient to ever receive DOPA by Dr. Hornikowitz was one of von Economo's original encephalitis lethargica patients. It very clearly showed that some psychiatric disease is a result of organic brain pathology and not, as Dr. Freud would have us believe, symbolic. So people that had these unusual motor tics did not hate their parents. They had actual brain pathology. So I like to call this the fall of the Freudian empire. It also had a huge impact, as you can imagine, as a social force. So there's all of a sudden a generation of neurologically disabled young adults that need chronic care. There's a large cohort of children, as I mentioned, with neuropsychiatric disorders. So this is the beginning of inpatient units for emotionally disturbed children, special education programs in public schools. And they really had to change laws to deal with this kind of outbreak of antisocial behavior by these poor kiddies that had survived encephalitis lethargica. And they actually was a law that had the marvelous name of the British Lunacy Law that dealt specifically with this. And of course, when we're talking about legacy as a social force, it led to a pretty darn good chick movie. So if you haven't seen Awakenings with Robin Williams and Robert De Niro, it's streaming online. I'll show you where later. It's worth watching, although De Niro kind of hams it up a little bit. It is still a worthwhile movie. And this, of course, is the story, if you don't know, of Oliver Sacks giving L-DOPA to these patients who were long-term survivors of encephalitis lethargica and magically awakening after they had been frozen for literally decades. Another potential legacy, not quite as well known or as well documented, is did encephalitis lethargica cause World War II? Now, bear with me here. It's a little bit twisty and turny. So Woodrow Wilson, the president of the United States at the end of the war, of the First World War, he, for the first time ever, a sitting US president left North America and went over to Europe in 1919 to be part of the Versailles negotiations. And when he left, he was a sunny, idealistic character that was going to use America's newfound power to make sure that it was a fair peace and that this would be the end of war for all time, peace in our time. While he's in Europe, though, he develops a severe illness with a fever and a delirium. And for a while, they actually feared that he wouldn't survive, although it was very much hushed up at the time. When he did wake up, though, he was said to have been a changed man, and he was kind of a persnickety old bugger and completely changed his position and was very much in favor of, making the Germans pay and getting retribution rather than what he had first gone over there. So I think most of us recognize that the very flawed Versailles Treaty is what led to the rise of this guy, Adolf Hitler, who you probably know was a corporal in the First World War, but you might not know that in about 1916, he developed a febrile illness, quite a severe one, and had to be hospitalized in the same hospital that Dr. von Economo described his patients in. Now, not surprisingly, all the records of Hitler's hospitalization were purged during the war because he didn't want anybody to know about this. But there's some pretty compelling circumstantial evidence. He certainly went on to develop atypical Parkinson's, and I'm going to show you some pictures of that in a second. He was known to have a severe insomnia. In fact, if you woke the Fuhrer up, you could be court-martialed or worse. And I don't think I have to convince you that he had a conduct disorder. So there's good reason to believe that Hitler may have had post-encephalitic Parkinsonism. And I'll show you this video that was unearthed in East Germany. I'm going to mute it. But you can see a very coarse tremor there as he's got his hand grasping a glove to try to stop the tremor. And another picture in a second, if you don't believe that one. And you can see the left hand, quite a coarse resting Parkinsonian looking tremor. And there are verbal accounts of Hitler having what looked like Parkinson's disease. So that's how it caused World War II. I don't know if you believe that or not. What are the implications of encephalitis lethargica for COVID? And this is where it gets kind of interesting and a little bit chilling. We know that COVID-19 is neurotropic, and autopsy of some of the folks that have died of COVID, even if they didn't have overt neurologic symptoms, there is evidence of microglial activation in the brainstem. And there have been case reports, not a lot of them, but definitely case reports of folks with COVID developing Parkinsonism. And I think what's most worrisome to those of us in neurology is this well-known phenomenon of COVID-19 prodromal loss of the sense of smell and alteration or loss of the sense of taste. That's a very well documented early sign of COVID. And this is also a very well documented prodromal symptom of Parkinson's disease, which has led some of us to kind of worry that in some of the folks who've survived COVID, we may see late onset Parkinsonism as sort of a post-viral Parkinson's. It's all very hypothetical, but it is certainly worrisome given the extent of the COVID infection in the world. Now, our second itis, I think I'm still good for time, yes, is poliomyelitis, which you'll be a lot more familiar with. It's also known as infantile paralysis because it's certainly early in its life, it was almost exclusively a childhood disease, and that would change in the early part of the 20th century. It's very much like the coronavirus. It's an RNA virus, but unlike the coronavirus, which is one of the largest of the RNA viruses, poliovirus is one of the smallest. So pico actually means very small RNA virus, picornavirus. It's of the enterovirus subgroup, and it has fecal-oral transmission. And it's really only expressed on humans and a few primates. And this becomes quite important in the later part of our story in terms of trying to get rid of polio. And it's really only quite rarely that polio enters the central nervous system. Although there'd been little scattered outbreaks for many years, there were usually only a few cases here and there. But in 1916, there was by far the biggest polio epidemic ever at the time. And it affected the Northeast United States and Canada, including here in Ontario. And there were 27,000 deaths, 2,400 in New York City alone. And these sorts of signs, when I used to talk about this, people would gasp in the audience. Of course, quarantine signs don't throw us at all these days. But at the time, it was just unheard of for the government to quarantine people and restrict social gatherings. Those were the days. What we now know about polio and what was learned from the 1916 experience, and hopefully we'll learn something similar coming out of the coronavirus experience, is this, and that's that 96% of infections with poliovirus don't even know they had it. So it's this completely asymptomatic infection, but you can measure the virus in the blood and in the throat, and they're excreting it in the feces, so they're infectious for 12 to 17 weeks, and they develop lifelong immunity. So 96% don't even know they had it. About 4 to 8% will have a minor, I don't feel well, kind of flu-like illness or maybe a GI illness. And same thing, they'll be infectious for a few weeks, shed the virus, and then lifelong immunity. And it's a tiny percentage, less than 1%, that go on to develop what we think of as polio, paralytic CNS poliomyelitis. This occurs in about 1 out of 1,000 children and much more frequently in adults, but still only 1 in 75. And some of those would have a nonspecific illness like this one beforehand. And sometimes they didn't. They didn't have the prodromal illness. They would just develop the paralytic polio. What this looked like clinically was, in a way, a little bit like a version of Guillain-Barré syndrome. But the difference was usually very high fevers, which you don't see in Guillain-Barré, and dramatic meningeal signs, almost like having meningitis, and much more asymmetric than Guillain-Barré. But like Guillain-Barré, a flaccid paralysis that would progress over a few days, more common in the legs and the arms, probably just because there's more nerves going down to the legs, can involve respiratory weakness. Unlike Guillain-Barré, there's no sensory involvement, so it's a pure motor syndrome. And in 10 to 15%, the dreaded bulbar involvement would happen. And this is where respiratory muscles would become involved and swallowing muscles would become involved. And to the medical profession at the time's horror, it turned out that recent tonsillectomy, which was of course mostly done on little kids, was a very dramatic risk factor for the onset of bulbar polio. So there's a lot of guilt involved in people who had been doing elective tonsillectomies in their kids, and it probably helped lead to the fall off in rates of tonsillectomy. So what happens at a pathophysiologic level is this. So the blood is, the virus is in the blood, it can get into the muscle, and in some patients, not all, it will be taken up by the postsynaptic neurons receptors, a specific poliovirus receptor, and it gets retrogradely transported, axonal transport, up to the anterior horn cell of the spinal cord. And once it's there, that anterior horn cell dies. So this becomes a sick, infected neuron, and it eventually dies off. And so all of those muscle fibers that were under the control of that particular anterior horn cell suddenly are not connected to the central nervous system anymore. And so, of course, they're not available to contract and contribute to the power the muscle can generate. And so that's the result of the reason that you get weakness in polio. What happens as patients recover, and fortunately a lot of them do recover, is the anterior horn cells that weren't infected, that survived, can basically reach out and take over the role of their fallen comrades, if you will. And so you do get good recovery, and often almost perfect recovery, not always, unfortunately. And this is why old Forrest Gump, if you remember the movie, was able to shed his polio braces because of reinnervation. I just couldn't resist that gif when I saw it the other day. So the prognosis of paralytic polio kind of depends on who you were, because children made a not bad recovery. A full third would recover fully, and the only way we know they have polio is they tell us. So people like former Prime Minister Paul Martin or Joni Mitchell or Neil Young, they all had polio when they were kids, but they made a full recovery. About 30% are left with a fairly mild paralysis, and about 30% have a medium to severe paralysis, like this poor fellow with the wasted limb, and about 10% die. But overall, adults had a much worse prognosis than kids. And that becomes important because there was quite a dramatic shift in the demographics of polio as the years went by. So in 1916, 95% of cases were under 9 years old, and only 5% were over 9 years old. But by 1955, which is the height of the polio era, fully a quarter of patients were adults. So why did this happen? Not only did the age demographic change, but the frequency and numbers in individual outbreaks were going up throughout the 40s and 50s. You can see they kind of peak there in about 1955. So what on earth was behind this dramatic change in the epidemiology and the demographics? Well, the theory is it's something called the hygiene model. And the essential message of the hygiene model is filth is good. So don't let your kids know that. But the theory of the hygiene model is that improvements in sanitation led to almost the opposite of herd immunity. So this was sort of herd vulnerability, because, as I mentioned, 96% of people who get exposed to the polio virus are asymptomatic, but they develop lifelong protection from it. So the less little kids in infancy were exposed to poop, the less likely they were to come across the polio virus. And when the little girls grew up and had their own children, if they had never come across the polio virus themselves, they were not able to pass on maternal antibodies as a booster infection to their little kids. So it leads to a higher number of people at risk. And nowhere is this better illustrated than with Franklin Roosevelt, another American president. He was an only child of wealthy parents and was homeschooled, so he had very few interactions with other children. And he ran for the Democrats on the vice presidential position in the 1920 election. They lost in a landslide. But as part of that campaign, he became the honorary, I don't know, poobah or whatever of the Boy Scouts and Cubs. And he took this very seriously, and he went, even after they'd lost the election, he went to the jamboree, and he was glad handing all the little fellows and playing with them and swimming with them. And presumably at some point, a polio virus found its way into his system. And after he left the jamboree, he went home to his summer house in Portobello, New Brunswick, Canada, and he became dreadfully ill. And you can see that this was actually almost exactly 100 years ago that Roosevelt was stricken with polio. And you can see down there at the bottom, I hope you can see it anyway, that what you read in the paper isn't always necessarily true. His physician, Dr. Draper, who would certainly have known better because he was quite a polio expert, said, but you can definitely say that he will not be crippled. No one need have any fear of permanent injury from this attack. And that, of course, was wildly untrue, because FDR was dreadfully crippled. He was severely disabled for the rest of his life, but it was very much a secret. So here's some pictures of him that look very casual, but they're actually quite carefully posed. So even though he looks like he's just casually got his elbow on his arm, he's actually holding up what amount to completely flaccid legs. And what you have to know is Roosevelt was a big guy. He was about 6'3" and very athletic before polio. And look here, you can see the edge of his tibia there. So he's got quite dramatic wasting of his gastrocs. And I think on this picture, you can see for a big fellow that's 6'3", there's not a lot of hamstring there. And here you can actually see his femur. So he's got very wasted quadriceps. You can see the edge of the tibia there. So he's got anterolateral compartment wasting. So very marked wasting. And here, although he's going to try to distract us by waving and smiling at the camera, I want you to keep an eye on his legs. This is him swimming in Warm Springs, Georgia. And watch how he moves his legs. He has to use his very powerful arms to lift himself up. And then in order to move the legs, he has to lift them. And you can see how, you just on the edge of the camera there, you can see how very wasted they are. And anytime Roosevelt in his political career was photographed, they were usually staged photos. So he was usually pictured sitting down, or if he was standing up, they were carefully staged so that he, again, looks very casual, but you can see he's holding on for dear life here and there. He had a special steel reinforced cane to help support him. He had special hand controls in his car so he could drive himself around, pardon me. And he had specially tailored pants to hide the fact that he was wearing these quite elaborate braces underneath his pants. And he was able to walk, but it was a very awkward, stiff-legged walk with people on both sides basically holding him up by the arms. So there's remarkably few bits of video of Roosevelt walking, and when he is walking, it's usually only for a few steps. And most of the time when the cameras weren't on, he was actually confined to a wheelchair. So America doesn't know it, but they have had a disabled president. So you could ask the question, did polio change FDR? And his wife certainly thought so. She said this: Franklin's illness gave him strength and courage he'd not had before. He had to think out the fundamentals of living and learn the greatest of all lessons: infinite patience and never-ending persistence. So that's a nice little statement. FDR himself was much more succinct. And he said, once you've spent 2 years trying to wiggle one toe, everything is in proportion. So definitely it changed him. The more important question is, did FDR change polio? And I think the answer is unequivocally yes. And that change started here at a little place in Georgia called Warm Springs, where he discovered natural hot springs. And there was a little hotel on the scene, and he went there after his polio illness. And he was really convinced that the natural hot springs there helped his rehab, that it made his muscles feel better and he was able to do more exercise. So we bought the place, and he would go on to turn it into what we would now call the world's first rehabilitation hospital. The term hadn't been invented there, but it really is the birth of rehab. And he liked the place so much that he expanded it, and they eventually had these marvelous hydrotherapy facilities and specialized nursing care and specialized physiotherapy and orthopedic surgeons on site. It was just a terrific place. There's a picture of him frolicking in the hot springs with his therapists and his fellow polio victims. And to this day, there's still quite a state-of-the-art rehab hospital on site at Warm Springs. Now, when FDR ran for president, he had to turn the Warm Springs place into a charity to avoid any sort of conflict of interest. Isn't that refreshing that a president would want to do that? And eventually he founded what was called the National Foundation for Infantile Paralysis, the NFIP. It would become known popularly as the March of Dimes because of this guy, Eddie Cantor, who was a very popular radio comedian at the time. And he got on the radio and kind of spontaneously one day said, hey kids, why don't you send your dimes to the president? And they did so. They sent them in the millions. There's fabulous pictures of Roosevelt with all these postal bags full of dimes. And if you don't know, by the way, that's Roosevelt's picture on the American dime. So the NFIP, or the March of Dimes, was a tremendous watershed event in charitable foundations. It was a real sea change. This is the first time you had fundraising by disease, which is hard to believe now because it's all by disease now. And it was also the first turn from a few wealthy benefactors, so the Rockefellers and the Carnegies of the world, to the multiple little guy donors. It was very much community-based, and the March of Dimes always promised to leave 50% of the funds locally, which was a huge help in recruiting volunteers. And they really were the first charitable foundation to realize the power of volunteer mothers. So mothers went door to door and basically shook down everybody give me your dimes to keep my kids and yours out of the wheelchairs, sort of thing. It's also, they also took advantage of Roosevelt's connections on Madison Avenue. So this is Mad Men Come to Philanthropy. And if you've heard the phrase poster child, that came right out of the polio experience. So, you know, your little dimes helped keep poor little Timmy out of the wheelchair, sort of thing. And they also have these awful and wonderful cinema shorts. If you want to entertain yourself someday, go onto Google and look at the YouTubes of the cinema shorts of polio, and they're absolutely terrifying. So they'd come on ahead of the movies, and there would be this shadowy figure with a deep voice saying, "I am polio and I'm stalking your child. Give now to prevent paralysis in your babies." You know, it was just awful, but it was extremely effective. They raised millions and millions of dollars, and they looked at their goals in 3 major categories. So education, support, and research. And education, as it would turn out, was probably the least important part of what they did, because a lot of the things that they were telling the public turned out to not be so true, particularly do keep clean. So that was probably less important than it might have seemed at the time, but there was a very important role in professional education. And I'm going to show you a particularly important part of that in a second. Support was a huge thing, because remember, this is America, where there's no socialized medicine. So they famously said, no polio patient, man or woman or child, shall go without the best available medical care for lack of funds. And this is hugely important, because a lot of this stuff was really expensive. I'm going to show you in a minute about iron lungs. And an iron lung actually cost about as much as the average American earned as an annual salary in those days, or about half of the cost of a house in those days. So it was tremendously expensive. And the March of Dimes said, don't worry about it, we're going to fund everything, you know, just relax. Of most importance, of course, was the research. And one of the polio researchers that had sort of struggled along before the days of the March of Dimes, desperately looking for support for his research and not finding it, said that the onset of the March of Dimes amounted to the sudden appearance of a fairy godmother of quite mammoth proportions who thrived on publicity. And you'll see in a minute how important that research arm was. So in terms of professional education, this leads me to the story of Sister Elizabeth Kenny, who was not a religious sister. She wasn't a nun. She was a nursing sister from Australia. And she really revolutionized polio care. And at least at the beginning of her North American career, she was very much supported by the March of Dimes. She would eventually have quite a public falling out with them and formed her own charitable foundation in Minnesota, I think it was. Anyways, prior to Sister Kenny, the emphasis was on rest and severe muscle immobilization. They would actually use rigid splints and even plaster casts to completely immobilize the poor little kids for weeks, or sometimes horrifically even months, if you can imagine it. And Sister Kenny said, this is all wrong. This is causing more harm than good. And she emphasized early mobilization, early stretching to prevent contractures, and most importantly, active patient involvement in retraining the muscles. And she did get terrific results and really revolutionized the aftercare of polio. She was said to, the more I read about Sister Kenny, the more I would think I would like to have met her, because she was said in a lot of the official publications to be a very aggressive and difficult woman. And, you know, I don't know about you, but when I see the phrase difficult woman, I'm thinking, but was she really, or was she just ruffling the feathers of the doctors? So there is a book about Sister Kenny that I'll have at the end if any of you are interested in hearing more. I think she's a character that's worth hearing more about. They actually made a movie about her in the 1940s with Rosalind Russell. That was kind of corny, but sort of fun. Anyway, I talked briefly about the iron lung. So the iron lung was invented in Boston in 1929, and it was called originally the drinker respirator, not because they use it on alcoholics, but because it had been invented by a guy named Philip Drinker. And the original one, believe it or not, was just a wooden box with a little hole here for the kitty's head to go through and a rubber collar around it. And it was hooked up to a standard commercially available vacuum cleaner, if you can believe it. So these were negative pressure respirators. As I'm sure you know, the ventilators and respirators that we use in ICU now are positive pressure ventilators, but the original ones were all negative pressure. And they went from the wooden box to the metal box, and that's where it became known as the iron lung. And you can see there's a window there so you can see what's going on. There's little ports for nursing care. There's a mirror so that the patient can see what's going on behind them. And the way it worked was this electric motor, what had been the kind of vacuum cleaner down here, was connected up to this bellows, which would move in and out and create negative pressure in here to suck air into the patient's lungs. Now, as you can imagine, taking care of patients in these things took really quite a bit of specialized training. And as more and more people were in iron lungs, they started to gather them together in these places called respirator centers, because it was quite a specialized set of nursing skills and so on that was needed. And the places, these respirator centers, would go on to basically become the early ICUs. And there were these folks called tank jockeys that were there, because you can imagine how awful it would be if there was a power outage or if the motor failed, the patient would die. So the tank jockeys were there, Johnny on the spot, to fix any mechanical problems. And these would slowly evolve into respiratory therapists, believe it or not. So you can tease your RT friends that their professions started out as essentially mechanics. But anyway, it was said that the leaders of the polio units became the pioneers of modern critical care. And that included this guy, Fred Plum, who was a neurologist that just died about 11 years ago, who was the director of the Harborview Respiratory Center, was one of the early ICUs in the world, and it was in Seattle. And he had gone into medicine because his sister died of polio, I think in 1945. And he would go on to be the brains behind all of these things that are just part and parcel of our neurology world now. So the locked-in syndrome, the persistent vegetative state. He was the co-author of the Glasgow Coma Scale. And he was the first person to talk about the so-called living will. So he was quite an important character in neurologic critical care. So most of the time, the iron lung was, you know, the way we use respirators now in the ICU. It was a temporizing thing to get people through the acute phase. And then eventually their diaphragms would reinnervate and they could come out of them. But occasionally in the rare patient, they never did reinnervate their respiratory muscles or their diaphragm, and they lived their lives in iron lungs. And there weren't a lot of them, but this woman was a woman named Martha Mason, and she lived for 61 years in an iron lung, one of the last surviving polio patients. So here's a little bit of Martha. She went on to get a university degree in her iron lung and actually had a career as a journalist, believe it or not. So here's Martha.
It's called an iron lung, and that's pretty obvious why. It takes over for your diet. It's like just a big can of air. I believe the last one was manufactured in 1977. There are other means of ventilation, and I've chosen not to do that.
So you heard Martha there say the last one was manufactured in 1977. But wait, Martha lies, because here we go again. COVID has changed everything. So with COVID, believe it or not, the iron lung is back. And in Britain, in the UK, there was at one point last year such a shortage of ventilators that some bioengineers kind of reinvented the iron lung, and they called it the exovent. So you can see it's much smaller than the original iron lung. But this picture of the actual working version of the exovent really does look like somebody took a hacksaw to an iron lung. And it was the same darn idea. So here's your glorified vacuum cleaner down here that's creating a negative pressure in there to help draw air into the respiratory system. So the iron lung is back, and let's hope we don't continue to need it. The real way that the March of Dimes, though, affected everything was the march to the vaccine. And in the interest of time, I'll probably skip over some of this, but it's really a question of the tortoise and the hare. So in this case, the tortoise was Albert Sabin, who was a scientist and really felt that a live attenuated virus was the way to go for the vaccine. And he, you know, time would prove him to be right, but time was the question. So his approach was going to take 10 years, and kitties were dying and being crippled. So Salk became the hero of the day because he pursued Jonas Salk, the killed virus vaccine, which was much quicker to bring to market. And indeed, by 1954, it was ready to go to trial. And the 1954 Salk vaccine trial was at the time the biggest human medical trial, clinical trial that had ever happened. And it really kind of set the standard for clinical trials with, you know, great follow-up, great documentation, a placebo arm, the whole 9 yards. And the little kids that were involved in this, they all got these little cards and these little pins. And to this day, you can see 70 and 80-year-olds that were part of the trial that still proudly show their polio pioneer pins. And as you can see down here in the corner, there was a Canadian connection. Connaught Laboratories at University of Toronto was a big part of the Salk vaccine trial. In fact, all of the vaccines given in the trial came out of Toronto. And the whole lead up to the success of the Salk vaccine was very much a Canadian story, because they developed the medium 199, and what was called the Toronto method, which was this over here. You can see this, all of these big glass bottles, they're filled with polio virus, and this machine would rock them gently back and forth. And that rocking motion allowed optimal conditions to allow the virus to multiply so that they could make enough vaccine to make enough virus to inactivate to make the vaccine. And the brains behind all of that was this unknown Canadian named Dr. Leona Farrell, who should be better known but isn't. So if you don't know, Connaught Laboratories was sold by Prime Minister Brian Mulroney in, I think, about 1984, which was a dreadful mistake. It was probably the leading vaccine producer in the world at the time. And as you know, we kind of got caught with our pants down in the coronavirus thing. There were no vaccine manufacturers in Canada at the beginning of the coronavirus outbreak. But I digress. As you know, the polio vaccine worked. It was a huge success story, and everybody was thrilled that this horrible threat of their kids getting polio was finally going to be in the rearview mirror. And here's Jonas Salk being interviewed by none other than Edward R. Murrow, and who asked him, who owns the patent on this vaccine? And he says, well, the people, I'd say. There can be no patent. Would you patent the sun? And I put that in there just to show you how much the vaccine world has changed, because I don't think Pfizer and Moderna are falling over themselves to make the vaccine free or give up their patents, but there we are. Now, the euphoria was somewhat short-lived, because although I said the Connaught Labs made the vaccine for the trial, when they actually went on stream with the successful vaccine to supply the whole world, they had to get other vaccine producers involved, and that included this small pharmaceutical company in California called the Cutter Labs. And they kind of took some shortcuts and didn't follow the Toronto method precisely. And instead of containing killed viruses, which the vaccine was supposed to contain, it contained a bunch of live viruses. And so these poor little kids got injected with live polio virus, and 260 of them got paralyzed and 10 of them died. So this was a huge scandal and led to dramatic legislative changes in the US and Canada, and the sort of tight controls we have on vaccine production these days. But even though there was that setback, it was eventually a success story. So you can see here, the last case of wild-type polio in North America was in 1979, and worldwide, polio-free there is in beige, and the polio endemic is in pink in 1988. And look what's happened by 2019. This is all polio-free certified. All of this beige is polio-free but not certified. And there's only 2 countries in the world, Afghanistan and Pakistan, where there's still polio infection. So it's very much a success story, and hopefully someday soon they'll even get rid of it in those remaining countries. The last little bit of legacy was the disability rights movement. So again, all these things that we take for granted now, the cuts in the sidewalk so wheelchairs can get up there, or disabled accessible bathrooms and this sort of thing, came directly out of the polio experience, because there was this generation of very highly motivated, driven kids really that had suffered through polio, and now they wanted their rights. They didn't want to get warehoused in asylums. They wanted to get out and live in the world. The final kind of sad legacy is that very population of driven kind of activist kids had something bad waiting for them in their future. At least some of them did. So you remember this diagram I showed you, where the neuron gets infected and then dies, but there's recovery when there's reinnervation. And what happened in many of the polio recovered folks is many, many years or decades after their polio, that reinnervated connection died. After a lifetime of this one neuron doing the job of 2 or 3 other neurons, I guess it just got tired out and the connection was lost. So they reaccumulated the weakness that they had fought so hard to overcome. It was really quite sad. And we still occasionally see cases of post-polio, but as the cohort is aging, of course, we're seeing them less and less commonly. So I hope I've convinced you that there's quite a legacy of polio, scientific and clinical and political. And if you're interested, there's a rich literature from the polio experience, pardon me, that's worth exploring. And just so that I can leave you with yet another frightening thing, some of you, certainly in the Ottawa area, will remember back in 2014 to 2018, there were, the first cases started in the US, but there were these cases of what looked for all the world like polio coming up in the pediatric population. And it turned out to be a related virus, another enterovirus, enterovirus 68, that caused acute flaccid myelitis. We had a couple cases here at CHEO in Ottawa, and the worry really was that you know, it might not be the polio virus, but it's something awfully closely related. And you know, is it going to be a case of here we go again? And about one of the few upsides of the COVID pandemic is little kids haven't been out playing with each other and passing their enteroviruses back and forth. So we haven't seen it in the last couple of years, but it's certainly out there, and it's a concern that we got to keep an eye on. So in summary then, if you are not in summary, but in closing, if you are interested in some books in all of your vast amounts of spare time, these are three that I would recommend. I really think everybody in medicine should read Awakenings by Oliver Sacks. It's far better than the movie. If you're more of a watcher though, there's a terrific movie about polio, is on Netflix right now called Breathe. And there's Claire Danes. The only thing that's off-putting is it sounds like Queen Elizabeth from The Crown's voice, but nevertheless, it's Claire Danes. And it's the story of Robin and Diana Cavendish and how he overcame severe disability of polio and kind of changed the world of the disabled. And I've already mentioned Awakenings is available on Prime Video. I promise I'm not getting kickbacks from Netflix or Prime Video. So, questions, comments, criticisms, I'll take it all.
Excellent talk, Dr. Pringle. Thank you so much for providing us with a great historical background, certainly as we're leading into, you know, everything that we're experiencing now with the current pandemic. So this is very, very informative. And I'm looking at some of the comments in the chat box, and a lot of positivity for the information you've provided us today. So we have about 5 minutes for questions. I'll start with a question from the chat box. So it comes from Andrew Kwan. He's asking if would exovents decrease the amount of pneumonia in ICUs?
Well, I'll start by saying, Andrew, that I'm not an ICU doctor, but one of my dear friends who just recently retired, Gwyn Jones here in Ottawa, long before the COVID outbreak, he said that the iron lung, the negative pressure ventilators were far more physiologic than positive pressure things. And he actually predicted that they would make a comeback. Now, I don't know that they would necessarily prevent pneumonias in all cases, because as you can imagine, if there's a lot of secretions, you can end up having the respirator suck them into the lungs. But it certainly would overcome the issue of intubated patients losing that safety gauge that's physiologically in there. So that's sort of a non-answer, I know.
That's great, thanks. There is one comment from Holly Richard. She's just asking if you wouldn't mind putting up the slide again with the books so that she can capture it. Any questions in the audience? Please feel free to raise your hand and we'll call on you. If you don't know how to raise your hand, you click on the participants box, and the three little dots on the bottom right-hand side should enable you to raise your hand.
Dr. Pringle's muted. We can't hear her.
I'll just mention that for whatever reason, possibly because I'm stupid, I can't see the chat box. I'm sure there's a way I could, but I have no idea what it is.
Oh, that's okay. I'm monitoring it for you. Sometimes when you're sharing your slides, it's a little bit difficult to see. Certainly provides a lot of context to what we're going through now.
Mm-hmm.
Like you said, many of the pictures with masks and isolation and quarantines, that's our new reality.
When I first started talking about this, I used to have to take a few slides to explain what's a pandemic, what's meant by herd immunity, and some of the basics of vaccine science and all of that. When I was putting this one together, I'm like, okay, I don't have to talk about that. Everybody knows about that.
That's very true. There's a question from Suzanne Bastiak asking about giving your thoughts on COVID long haul patients and their possible journey.
Yeah, you know, Suzanne, I just saw something this morning while I was sucking down my morning coffee about how prevalent long-term side effects are turning out to be in the COVID long haulers. And I think everybody's sort of knew that already, but now there's some actual data showing that the far more than 50, I've forgotten the actual number, I think they said 75% are turning out to have long-term effects, not just neurologic ones, but obviously lung damage and so on. And I think that's what's so frightening about the link with Parkinson's, although it's a somewhat tenuous link. It's a kind of a scary one in light of encephalitis lethargica. That what I didn't say during the talk is at one point in the 1920s and 30s, fully 2/3 of patients in Parkinson's clinics were post-encephalitic Parkinson's. So they were by far the majority of Parkinson's patients were these people who had this presumably inflammatory disease. And in fact, one famous neurologist stupidly predicted that by 1980, there will be no more Parkinson's disease because the cohort will have died off. So of course that didn't come out. So that's what worries me is I actually think there's a good chance that we may see some of these long-term neurologic sequelae, but maybe I'm just being an alarmist.
All right, thank you. We're at 11:15 now, so we very much appreciate your talk today. It was very informative.
Thank you all so much. I'm so honored to have been here, and I'm going to leave you now, but all the best and everybody stay safe.
Thank you so much. For everyone on the call, the next session is in a separate Zoom link, so please go to your agenda and click on the next activity.